Dr. Kevin Kavanagh is a retired physician, founder of a national organization called Health Watch USA. He's had a little medical leave for the last several weeks, but he is back at it this morning, and we're delighted to welcome him back. Hey, Dr. K.
Hey, Jack. Glad to be here.
I tell you what, man, I missed you.
Well, I missed you too. I'm just glad to be able to get through it and be back on the show.
Boy, you sound great. You sound strong. How much of your experience are you willing or wanting, if any, to share?
Well, I'm open to about most. I'm kind of old and don't have many airs about me, and I think that the experience is good to share with people. And it was, of course, hard to do this during a COVID pandemic. The procedure was, I think, initially delayed because they had so many COVID patients to take care of and a backlog of people, and then it got canceled and put off again. And this was for prostatic cancer. Of course, that's a low-grade cancer, but that's like being a little bit pregnant. It either is bad or not bad. There's no mild about it. You either aren't having problems or people are deathly sick with it. And so that's not much help. And I think one of the things I was told by everybody was, well, you'll probably die of something else. And I can tell you as an older individual, that's not much comfort. If you're worried about dying of, dying of issue A, you don't need to be told, oh, you're going to die of something else sooner. That's actually bad news. So
yeah, that's bad news. That's not good. That's not good. Was your experience, I know it's not pleasant when you have surgery, but was it favorable? Obviously, you come through it well and everything was a success. Tell us about that.
Yeah, it was very favorable. It did cause my arthritis to flare. I had probably more pain from my back and neck with this than I actually did from the surgical site. That being said, I only had to take 1/2 dose of Oxycontin through the whole episode. The rest I controlled with Tylenol and just kind of toughed it out. But nevertheless, it was a hard experience to go through.
Well, I can't get over how chipper you sound. That's wonderful. It's great. And we're very happy to have you back. Now, you have been critical of hospitals and doctors' offices and clinics and what have you for a long time in terms of sometimes the diseases that they spread. And I know that you probably had deep concerns about that in going into the hospital to have anything done. Have you changed your mind at all after this experience?
Well, actually, no. I think things are running on a shoestring. At the time I was getting the procedure done, they were still very much overcrowded with COVID patients. Facilities are still short-staffed. They're short-staffed on nursing. They are doing above and beyond. And it's tough to run a facility at the same level it was running pre-COVID. This is placing a tremendous strain on our healthcare facilities and on our healthcare personnel. So when people start talking about COVID and COVID deaths, there's a lot more death and disability that's being caused from this pandemic than just from the virus itself, but also due to the strain on the healthcare system and individuals not being able to access the system. And for example, if my cancer comes back years from now and I wind up dying, and it did that because the procedure was delayed, I won't be counted as a COVID death. And there are many people in that situation. A lot of people have heart disease, they have lung disease that needed to have prompt treatment that they didn't get that in the ER. And so there's a tremendous amount of collateral damage that this pandemic is causing. And that is something that we need to at least set a bar where we don't collapse our healthcare system. And I think that's something that we still need to work on. I think a lot of the COVID deniers need to get it through their heads that, this is impacting many, many people, not just those that contract the virus.
We hear this morning that vaccination rates in Kentucky have been overestimated. What's that about?
Well, and that's a disappointment. From what I understand, that's due to one of the vaccine providers. I think it was Kroger. They by mistake inadvertently put in people twice, I guess, and it's resulted in about a 5% decrease in our vaccination rates, which is not good. You have to realize that our full vaccination rate for our population right now is standing at probably 56 to 57% in Kentucky. Cambodia, all right, this is Cambodia. They're about 79%. So we're not even doing as well as some third world nations. We're probably 52nd in the world as far as vaccinations, well behind other industrialized nations. Many European nations are doing far better than we are. For example, Portugal, they're in the 80s, I believe 86% fully vaccinated for their population. That's not who is eligible for a vaccine. That's for their entire population, including the kids. So we've got a long ways to go. And I know vaccine mandates is a very hot issue, but I view this as a national security issue. I am concerned, like many of our leaders, that this virus may actually be one that was manufactured in a lab. And if it is, it doesn't make much sense not having our armed forces vaccinated and our frontline responders. You can't respond to a bacterial pathogen or something you think is being designed by just laying down and say, okay, let it infect us. It's almost like having a mentality of when you're at war, you may need a draft. Now, I'm not saying it was a biological weapon or it was done on purpose, but I think there's more and more evidence that's starting to mount that this may have been made in a lab and got out spontaneously or by mistake. And one of the things that I'm hearing repeatedly is that this virus from the get-go just spread phenomenally well and was adapted to humans. And that is something that you wouldn't expect at the beginning when a virus just jumps from a bat to mankind. And I've heard that from both Dr. Fauci, from Scott Gottlieb. All of that is a concern. And of course, there's a lot of other anecdotal evidence and suspicions, etc., that has arisen. So I think the lab theory isn't some right-wing conspiracy theory. I think it is on the table, and many feel that it's the most prominent one.
Let's talk about the FDA authorization for vaccines for kids 5 to 11, even though the panel approved them, the whole board has not approved it yet. Is that correct?
I think it still needs to go before the CDC, and that's the final approval.
CDC.
Yes.
Kids 5 to 11 be getting the vaccine if and when it's approved?
Oh, I think definitely. If it's approved and it's deemed safe, which from the data I've seen, it has a very good safety profile in the young children, I would recommend it for my grandchildren and hope their parents will take them down and get them vaccinated. I should note that the studies are relatively small right now. It's about 4,500 kids in the study and maybe 2,000 were in the experimental arm. So they're not huge, but this is on top of the safety data that you've seen with adults, and it's also on top of the data that we're getting from hospitals regarding infections in kids with the Delta variant, which is really quite concerning. You're talking about close to a 2% hospitalization rate. Long COVID also can occur. Dr. Hortez, I heard, was stating that about 14% of children are developing long COVID that are hospitalized. Dr. Fauci said that overall 4 to 6% of childhood infections may have long COVID. And so this is something that you want to avoid. And all of the complications that I've seen, including myocarditis with the vaccine, are relatively rare compared to that if your child gets the virus. And believe me, there is a high likelihood of getting the Delta variant because it spreads like you can't believe. And of course, you've got the Delta Plus variant that's even more infectious. Luckily, however, that doesn't seem to have taken hold yet in our nation. So yes, I would definitely recommend talking to your physician and seriously considering for the health of your child getting the vaccine. And that's what I'm going to be recommending for my grandchildren.
How about this mix and match business? We heard for a long time that when you get your booster, be sure and get the booster of the same brand that you got your vaccination. Now they're saying it's okay to mix and match it. Is that correct?
Yes, and there actually may be some benefit to that because you're giving your body a different type of immunological exposure, kind of like if you had an infection by two different strains as opposed to the same strain repeated. And so I think that's good. And certainly for the Johnson & Johnson vaccine, the data is really supportive of mixing and matching with an mRNA vaccine, something like a 76-fold increase in antibody response. And all of these vaccines are waning. Johnson & Johnson, though, is waning more than the others, and so I would really encourage those that have Johnson & Johnson to get a booster. And Jack, I think we need to state on the front end that these boosters may actually just become part of the vaccine schedule. If you look at normal, everyday vaccinations, which are given to children, I think they go through about 34, 35 different jabs in their lifetime. But under the age of 2, many pathogens, the vaccines are given 3 to 4 times in the normal course. And that would include hepatitis B, rotavirus, diphtheria, Haemophilus, pneumococcus, polio, all of those. None of them are given just 1 or 2 times and you're good for life. So I think really on the front end, when people were saying, well, get 1 or 2 vaccines and this may be it, that was probably very optimistic because there are very few vaccination protocols that's what happens. Usually you need to have multiple ones. And with the booster, it doesn't mean that you're going to have to get a booster every 6 months. One of the things that's been noted with the booster is that about 5% of the people will develop some transitory or limited lymphadenopathy, which may be a sign of more durable immunity. So like the other vaccination schedules, after the 3rd booster, that may be it for a number of years. It may take a 4th booster, or God forbid, if we get another variant out, you may need a different formulation of the vaccine. So I think we're going to be in for some more repeated vaccinations, but hopefully at a much slower pace than what we saw this year.
Can you talk about the new study from the VA regarding boosters?
That is one that was looking at prevention of infection. So this wasn't hospitalizations or deaths, meaning the vaccine still can be effective in cutting down hospitalizations, but it was looking at infections. And when they say preventing infections, they mean symptomatic and asymptomatic. The J&J by August was only 3% effective, Moderna 64%, and Pfizer 50%. So the J&J is really a vaccine that needs to get a booster. That's one of the reasons why the CDC said everybody should get a booster who's had a J&J, and they said get it from 2 months after your initial vaccination, 2 months or greater. So if you're 6 months, you need to go down and get one.
All right. Let's see. We've only got about 2 minutes left. You want to talk about ventilation in schools?
Yeah, and I think that's very important. We need to up our game in ventilation. I think either with upper room UV filtration or centralized ventilation, we need to get the air exchanges up. That's one of the keys. Of course, masking is also very important, but it really isn't as effective with the Delta variant as it was with others. It will make things better, make your chances less of catching COVID-19, but you need that added layer of ventilation. And one of the things parents are doing is that some parents are getting a carbon dioxide monitor. That's not monoxide, it's dioxide. It's the $250 monitor, not the $25 one, to measure carbon dioxide parts per million, and you'd want it under 1,000 to test the air of indoor environments. And that's probably a good idea because I don't really think at this point we're investing in the infrastructure of ventilation, and we need to do that. That's not only going to be important with the coronavirus, but it's important with colds, it's important with flu. We really do need to get pathogens that are transmitted at least somewhat by the air. We need to get those more under control by paying attention to ventilation.
And you've mentioned Delta a few times. I was kind of under the impression we were sort of on the back end of that was kind of going away.
Well, we are, and the data looks very good. It's going away. I don't see a variant that's taking off, and this includes the Delta Plus. You'll hear a lot about that, but that's really been around in the United States since mid-July, and it's not increasing in numbers. That's unlike last June when I was looking at the Delta variant that was exponentially increasing, and that's when we sounded that alarm. But what's of concern is that the Delta Plus variant is really resurging in England and causing a lot of disability and starting to cause deaths. And we're concerned about that. So it looks good, but we need to keep our vigilance up.
Dr. K, great to have you back. Thank you so much.
All right. Thank you, sir.